Good evening, everyone, and a very warm welcome to all of you. Myself, Neetu Abraham, Community Manager at MediSage. MediSage is a platform made by the doctors for the doctors, created to foster continuous knowledge sharing, meaningful learning, and a professional collaboration. On behalf of MediSage, I am delighted to welcome you to SexMed Connect to Sexual Health Ki Pathshala Episode 1, where today we will focus on the topic Sensate Focus Therapy. Now, I would like to invite the MOCs Dr. Shama Sultana and Dr. Naisargi Patel to carry forward this session. Over to you, ma'am.
Thank you. Good evening, all. Welcome to SexMed Connect's Sexual Health Ki Pathshala Episode 1 on Sensate Focus Therapy. It is a therapeutic technique to enhance intimacy and sexual satisfaction by focusing on sensory experiences. We have an expert faculty, Dr. Ala Satyanarayan Reddy Garu. Before we introduce our faculty for the session, I would like to introduce about our SexMed Connect forum and have our president and vice president of the SexMed Connect to address notes. To tell about our SexMed Connect, it is a sexual health forum for gynecologists to understand and learn about sexual health issues. It is initiated by Dr. Neeraj Jadhav sir, and he is a past chairperson of Sexual Medicine Committee and also now vice president-elect of West Zone, FOXY. We have exclusive WhatsApp group for gynecologists where daily case discussions on sexual health topics could be done, and various other social media platforms of SexMed Connect shares information and updates about the forum. We request doctors to follow us and on our platforms and take benefit of all these initiatives. Now, I would like to invite our President of SexMed Connect, Dr. Neeraj Jadhav sir, to address and give insights about today's topic, Sensate Focus Therapy.
It's okay, Sama. You can just introduce our faculty and then go ahead. No need to any formality.
Okay. Our faculty of today, Dr. Ala Satyanarayan Reddy sir, he is after being an active clinical practice of OBS-GYN for 30 years, specialized in sexual medicine by acquiring masters in psychology and fellowship in European College of Sexual Medicine. He was retired from Vinayaka Missions University and as adjunct professor in reproductive and sexual health, Indian Institute of Public Health. Earlier was consultant in reproductive and sexual medicine at Apollo Fertility, Hyderabad. For past 14 years is in exclusive practice of sexual medicine at Leo Institute of Sexual Medicine in Hyderabad. Was executive committee member of Council of Sex Education and Parenthood International. Now is vice president academics of Governing Council of newly established Indian College of Sexual Medicine. He published 50 research papers, 17 books, and Handbook of Sexual Medicine, Sex Therapy, a clinical guide, and sexual facets of medical diseases. He received Best Doctor Award 6 times and Chief Minister's Gold Plaque 2 times from Government of Andhra Pradesh. His areas of interest are male factor in infertility, unconsummated marriages, and sex therapy. We invite you, sir, for this session. Please give your insights. Thank you.
Dr. Shama, thank you for a nice, warm introduction. I am Dr. Satyanarayan Reddy. I am practitioner of sexual medicine now. Earlier, obstetrician and gynecologist, having my own private nursing home in far away from Hyderabad. Now I do exclusive sexual medicine practice. Thank you for inviting me for talking about on the topic of sensate focus. The first one is sensate focus is not an individual, it is a base. Sex therapy is the ultimate. So we go step by step to teach because it is a pathasala, it is written there. In fact, sex therapy has to be learned in a Gurukul style only, not by teaching. Very simple. You have to learn from your guru. It comes out of experience of it. So sex therapy is a specialized form of psychotherapeutic techniques designed for the management of psychological sexual dysfunctions in both men and women. The foundation for sex therapy is sensate focus. Sensate focus don't have an individuality. That is, it is the foundation for sex therapy, and sensate focus is the first and essential step in all the cases of sex therapy. No matter what the sexual dysfunction may be, whether it is erectile dysfunction or female orgasmic disorder, sensate focus forms the common base. The second part of the therapy then becomes individualized with the technique tailored to the specific sexual dysfunction. To understand this one, a similarity I will show you. Suppose to prepare different rice varieties such as jeera rice or tamarind rice or mango rice, the base is always cooked rice. And the flavor and uniqueness comes from the additives only, like a tamarind or mango or a egg. In sex therapy, sensate focus is the cooked rice. The condition-specific techniques, that is for the sexual dysfunction, condition-specific techniques are the spices and flavorings only for the therapeutic intervention of the psychological sexual dysfunctions. And it is a specialized form of psychotherapy. It is not psychotherapy. Psychotherapists cannot do sex therapy. Sex therapy is a specialized form of psychotherapy. Less than 5% of the psychologists, less than 5% of the psychiatrists, or even less than 5% of the sexologists actually practice sex therapy in its true form. Most medical doctors have only a vague idea of what sex therapy entails. And even among the practicing people also, the understanding often remains incomplete and foggy. It is clouded in mystery. Therefore, in this session, I first take you through a bird's view of sex therapy. What is it? Why it is important? And how it is structured. Following this one, we shall move into the concept of sex therapy and finally practice and applications in various clinical settings. Now we go for the real ones. And the learning, here I wanted to warn people, the learning curve of sex therapy is so long. It takes so long time to learn sex therapy, and mastering it requires a structured curriculum followed by a guided training, not training, guided training guided by somebody else. Now this lecture is intended as the first step of teaching. Now I share the screen. This is purposeful. I designed it so that it denotes a sex therapy, medical and male and female. So sex therapy, a primer, just to know what is it. Now today we learned what is the psychological basis of sexual dysfunctions, what are the psychological interventions for the sexual dysfunctions, and who are the couple clients for sex therapy, the concept of sex therapy, the practice of sex therapy, and if time permits, we look into the sex therapy for specific sexual problems. Now we go for the causes of the sexual dysfunctions. It can be biological, psychological, or combined, or it can be relational and situational also. Exclusively psychological or psychological factor is the cause of the sexual dysfunction, or it is the effect of the sexual dysfunctions. In good number of instances, there can be a psychogenic cause associated with a biological cause also. Today, we restrict ourselves to the psychological causes only. Now, in the psychological causes also, there are 2 or 3 distinct varieties. Every human being is having his own identity, his own personality. Some are extrovert, some are introvert, some are timid people, some are outgoing people. So, if it is in extreme, it is called personality disorder. So, everybody will be having a personality. And everybody learns over this personality, learns to the society some techniques. But there are some immediate causes. There are some immediate causes that provoke a sexual dysfunction. So, immediate causes that provoke sexual dysfunction we are concerned with today. So, the immediate causes, everybody thinks that they are such a great thing to learn. No, a simple knock on the door during intimacy in a hotel room, or a smell of alcohol on a partner's breath, or a dissatisfied look from a spouse after intercourse, a sexual demand on the day of ovulation, or a lack of communication about what she or he wants. These are very silly things. A single episode of sexual failure is made perpetuated, or is perpetuated by means of three mechanisms. A immediate cause provokes an individual who is predisposed. So the conditions of personality and learned causes predispose a person to develop a sexual dysfunction with a small immediate cause. But the immediate cause has to be, but the immediate cause results in a single failure, but the single failure has to become permanent or regular failure. That is, it is by means of three mechanisms. So the three mechanisms are performance anxiety, spectatoring, and loss of abandonment. All of the words look so confusing. Performance anxiety is nothing but performance anxiety at performance. That is, performance anxiety is anticipating a failure in the present sexual concept. Today he is doing sex. That is anticipating a failure in the present sexual concept based on previous failures. It is such a simple thing. It is not anxiety over performance simply. It is anticipating a failure in the present situation because that a past failure. This is performance anxiety. He approaches sex with a failed mind, anticipates failure, worries about the consequence of the failure. Then the consequence of failure is more troublesome than the original sexual dysfunction itself. So to give an example, suppose somebody always goes with a man. I want to enjoy sex. Suppose he is not good at bed, then next day he goes, I must perform sex. Suppose he is not successful in that one, then he goes, approaches the wife, I should achieve erection. Then next time when there is a failure, I may not achieve erection. He goes. Then he becomes, I cannot achieve erection. Finally, he comes to a conclusion that I am impotent, my wife may leave me. This is a gradual downhill escalator course. Our job is to make it reverse. So just to tell you a little, it is a clock. Always man should be like this in 12 o'clock position. Always, suppose he falls down by 1, 2, 3, he comes down to 6:30 only. This is literally a mischievous person's idea of 12 o'clock and 6:30. Just to be a little lighter. Then this is performance anxiety. There are two more things called spectatoring. The words looks bigger, but when we go directly into it, this one normally, the words are so easy to learn. Spectatoring means normally in a bedroom, only two people are there, the boy and the girl. But when you are doing sex, there is a third person inside the room. That is Atma of the performer. He is clinging onto the roof, to the fan, and then looking at. That is, in this situation, in this scenario, the man is performing. At the same time, he is judging his own erections. This is called, he is spectatoring himself. When he is judging himself, he is always failure. The next one is loss of abandonment. The words are bigger. No, it is so easy. Normally, at sexual act, you have to abandon yourself to the lust of sex. I use the word not love, lust of sex. Anybody has to abandon his whole self to the lust of sex. Only sex is there. And if he is not able to abandon himself to the sex, then he can't perform nicely or she can't perform nicely. So it is just like when you go to a temple, you see the god, and then your mind should be always on the god itself. But always our mind is on the chapels we leave outside. This is called not having a loss of abandonment. These are the three basic factors that make a single entity of failure into permanent entity. Now, sex is an art. Sex is an act. It is an act of intercourse. At the same time, sex is an art. I repeat the word, sex is an act, and at the same time, sex is an art also. It is an art. So sex therapy is also an art. Anybody has to learn that art. to describe sex failure and sex therapy in an artistic way, let us consider this metaphor. It is the pleasure of the bee to gather honey of the flower. It is the pleasure of the flower to yield its honey to the bee. For the bee, a flower is a fountain of life, and to the flower, a bee is a messenger of love. And to both bee and flower, the last one is the giving and receiving of pleasure is a need and an ecstasy. This is what sex is in an artistic way describing. Now we go, this is a nice picture of a bee on the same bee on the flower. The bee is resting on the petal. Nice colorful picture is there. Everybody likes it. But the honey comes or the nectar comes from the central stylus, but it is sitting over the petal. But so it is not able to gather honey from the flower. Now you can see closely, the bee is wearing a dejected and melancholic look. You can see it there in the eyes if I tell. It is, they see the bee, this is symbolic of sexual dysfunction. The potential for fulfillment exists, but it remains unrealized. This is sexual dysfunction. Now to go into sex therapy, the solution lies in communication, and still communication, and in touch, and again the touch. Through open expression, mutual sensitivity, and guided therapeutic exercises, we are guiding the couple, therapeutic exercises such as sensate focus, the couples rediscover their intimacy and pleasure. So, in the words of the Omar Khayyam, this is sex therapy. There is a door to which I found no key. There was a wheel past which I could not see. This is the mentality of the couple who are coming to us with a sexual dysfunction. And the treatment is some little talk a while of me and thee. There seem, and then no more of thee and me. They are united. This is the basic principle of sex therapy. Now we go. Everybody thinks that psychotherapy, psychological intervention, psychotherapy, sex therapy are same. Everything is entirely different. When there is a sexual problem, we can use a Plicit model. The Plicit model is not a technique. It is a stratification of the treatment schedules. In good number of instances, the patient permits, no, the doctor permits the patient to talk for his own problem, and the patient gives us permission to discuss the problem or to listen his problem. In most of the instances, this permission of exchanging ideas between the client and the doctor is enough. Very few people then go for, in 50% is enough. That is patient listening to the patient's problem. Then a limited information is given. Suppose somebody is having less erection at 70 years of age. If you tell that it is quite common in elderly man to have a little more extra stimulus to get erection, this is enough. If somebody tells that I am having less volume of the semen at 60 years of age, we have very simple information that is normal is enough. But for some cases where there is a problem, a specific suggestions are given. Just like do more foreplay for having less lubrication, or you do stop and start technique for premature ejaculation. These are specific suggestions are given. The last one is intensive therapy. That is, intensive therapy is needed only in less than 5% of the case of psychological sexual dysfunctions. This is the sex therapy is one of the intensive therapies, and the other one is cognitive behavior therapy. So we restrict ourselves to the sex therapy only today. Now, earlier psychosexual therapy was there, but till Master St. Johnson, they identified they structured a sex therapy. It is only psychoanalytical psychotherapy, which used to take at least 2 years for those people. Then from Freud to invention of Viagra, it is only sex therapy and cognitive behavior therapy only. Post Viagra, it is integrative. Now we are using biopsychosocial therapy only. Now, what is the hypothesis? That is, Masters and Johnson told that sexual dysfunctions may have a deep-rooted causes. There is a personal disorder, but it is the immediate causes that trigger sexual dysfunctions. Addressing the immediate causes relieves the problem. This is the basic concept. This is how to relieve the immediate concerns. This can be achieved by specific exercises. This is the hypothesis of Masters and Johnson. Now we go for the basic principles of sex therapy. Sex is a natural function. Sex is a natural function. Just as hunger leads to eating, sexual desire is a natural drive leading to intimacy, reproduction, and pleasure. In a sexual dysfunction, the next one, in a sexual dysfunction, there is no uninvolved partner in a couple with sexual dysfunction. One may be experiencing a sexual problem, but the other partner is contributing the problem or a sufferer of the problem. So there is no uninvolved partner in a couple with sexual dysfunctions. So neither the man, even if he is having ED, neither the man nor the woman is our client. It is the couple or our client, and the marital unit is our client. So it is the immediate causes that initiate and maintain sexual dysfunction. Intrapsychic factors may be there. Or the next one is resolving or circumventing the immediate causes resolves the sexual dysfunction. This is the basis of sexual sensate focus on sex therapy. So here the cause is not relieved. The cause of sexual dysfunction may be a personal disorder, but that is not relieved. It is only symptomatic treatment only. The here and now causes are addressed. It is just like for a diarrhea, you need not do anything. You replace the fluid. The same way, the immediate problem of sex failure we are addressing. So to describe, now we skip this one. Now to illustrate this one, imagine the Ganges river is in flood. It is having full of crocodiles and snakes also. The man is on one bank of the river. The woman is on the opposite bank. They have to meet, but they cannot reach each other. One option is to teach the man how to swim, but it is so risky. It is so time-taking. He may be washed out in the flood. So the other option, a better solution is you give brick and cement to the couple. They construct a bridge over the river Ganga, and they can meet now. They construct a bridge. They can meet now. Likewise, in sex therapy, bypasses the deep flood of remote cause and instead focusing on bridging the connections between the couple. This is what the flood is there. They construct a bridge and nicely charting. This is the basis of sex therapy. Now, and it is only for the couples in a steady relationship. It is not for a single person. Earlier, surrogate partners were employed, but it is discontinued now. Now, who are the candidates for sex therapy? Every candidate who is having a psychosexual dysfunction is not a candidate for sex therapy. It is a couples with psychogenic sexual dysfunctions. The partners living together can invest time, and they should have a confidence in themselves that they can do. They should have a confidence in the technique, and they should have a confidence that the therapist can deliver the goods. These are the prime requisites for choosing a couple for sex therapy. Now, to become a sex therapist you should have some prerequisite, not just like anybody else. Sex therapy is not for the In clinical practice, sex therapy is most frequently used for erectile dysfunction in male, unconsummated marriages, delayed ejaculation, or low sex desire, anorgasmia, and vaginismus in a woman. Every doctor cannot be sex therapist. The basic quality should be the therapist should be equally comfortable. The therapist should be comfortable with his or her own sexuality. The first condition is we should be comfortable with our own sexuality. Then he should be comfortable with or deal with the intimate personal matters of both men and women with equal eloquence. While dealing with intimate matters of sex and therapy, here there is a lot of difference, lot of problem in doing sex therapy is the therapist when dealing with intimate matters of the couple, the therapist can develop romantic feelings towards the client of opposite sex. The second one, the therapist can induce romantic feelings in the client of opposite sex, or the client of opposite sex can induce romantic feelings in the therapist. She or he can induce the sexual feelings in the man, in the therapist, or the client of opposites can develop romantic feelings towards the therapist. If people cannot resist this temptation, they should quit the job. And the therapist has to have invest so much amount of time. That is, and it is not a lucrative practice, even though we charge heavily, it is not a lucrative practice. Now, what is the schedule of the sex therapy? Because none of you are more comfortable in practicing sex therapy, a little detail. Sex therapy generally conducted in 6 to 8 sessions, with each session lasting for about an hour. 6 to 8 sessions, each session lasting for about an hour. For us to interact with the clients. The couple typically comes once in a week, roughly. Total, it takes around 2 months time. At the initial visit, the couple are introduced to the overall technique. Then they are taught specific exercises, but these are not demonstrated in the clinic. You have to impress upon the couple that they are not demonstrated there. Instead, the couple is instructed to practice the exercises at home for about an hour each day. It is in the privacy of their homes only. We teach, we don't demonstrate. The patient has to, the couple has to, we have to use the word clients. The couple has to practice there in their homes. After 3 or 4 times practicing the same first technique, they come back to us after 4 or 5 practice sessions with the same technique. They return to the therapist, usually after a week. During the follow-up sessions, the therapist seeks feedback from the couple, whether they did it or not, whether they did it correctly or not, whether they are comfortable with doing it, what is their experience of doing it, is it boring, as it is a pleasant one, and if they are ready to continue. If the therapist is satisfied that these people did it correctly, then we go for the second technique. Likewise, continuously once in a week they come and then learn the techniques. In practice, about 3 or 4 sessions are needed for doing sensate focus, and 3 to 4 sessions are needed for managing the specific sexual dysfunctions. So it depends upon the sexual dysfunction. Some may need 2 or 3 sessions only. Some may need 4 or 5 also. Good number of people may. Total put to on an average, it is around, book says only 6 sessions, but usually we take around 8 sessions also. 6 to 8 sessions. Now, what is the format of the sex therapy? The sex therapy is consisting of 2 parts. One is a sensate focus, and the second one is techniques for individual sexual dysfunction. The sensate focus is common to all forms of sexual dysfunctions. The therapeutic interventions are different for each sexual dysfunction. Dysfunction specific therapy it is called, that is tailored to the individual sexual dysfunction like erectile dysfunction, or anorgasmia. Now, to make your things a little softer and lighter, the term sensate focus sounds new, complex, and foreign. And in fact, the word sensate focus is intimidating to the learner. It is really intimidating. I too felt like that, intimidating to the learner. It is simply focusing on sensation. Sensate focus is nothing but focusing on the sensations, that's all. If you tell that it is focusing on sensations, people may be opting for it, practitioners may be opting for it. If you use the sensate focus word, we are frightened of that word. The next one, in the same way, the title of the procedure, sex therapy. The couple, when you tell you have to do sex therapy, that to the couple and the client, it looks like these people are going to demonstrate how to do sex. Or they think that we are going to observe them doing sex and then pointing out where is the mistake. This is quite common by using the words called sex therapy. If you rephrase that word called sex therapy, then that is psychological treatment for sex failures, then more number of the clients will be coming. If you rename the sensate focus as focusing on sensations, that intimidating factor of learning new things is lost. So, just in a funny way, I feel that the psychologists or psychotherapists purposefully have given a complex names to drive away other practitioners to learn sex therapy. Personally, I feel it so. Then, sensate focus. And the key rule during sensate focus is they are forbidden to do intercourse. Fundamentally, they are forbidden to do intercourse during whole of the sessions of sex therapy, sensate focus. The aim is not performance of the sex act, but awareness and enjoyment of the physical sensations that they receive. Now, the sensate focus is having non-genital pleasuring, genital pleasuring, integration of the genital and non-genital pleasuring together. And there is another one optional, which our Indian people need. Optional is genital stimulation pleasuring. This we add usually. Now, the first step is non-genital pleasuring. This involves gentle touching or caressing of the part of the body. The focus is purely on identifying the feel of touch, not on arousal or on the response of the partner. The couple is asked to prepare for bed, undress themselves and then relax. And without spoiling the originality with my poor broken English, the original description of the technique by Helen Kaplan, I am showing it here. And you can read it nicely. I would like you both to get ready for bed, to take your clothes off, shower and relax. I want you, the woman, to lie on your belly. Then you, the man, caress her back as gently and sensitively as you can. Move your hands very slowly. Begin at the back of her neck, caress her ears, and work your way down to her buttocks, legs and feet. Use your hands on her lips. Concentrate only on how it feels to touch her body and her skin. The next one, in the meantime, I want you, the woman, to focus your attention on the sensations you feel when he caresses you. Try not to let your mind wander. Don't think about anything else. Don't worry about whether he is getting tired or whether he is enjoying it or anything. Be selfish. I repeat, be selfish. And just concentrate on your sensations. Let yourself feel everything. Communicate with him. Don't talk too much, or it will interfere with your responses and his. But remember that he can't possibly know whether you are feeling unless you tell him. Let him know where you want to be touched and how, and where his caresses feel especially good. And let him know if his touch is too light or too heavy, or he is going too fast. If the experience is unpleasant, tell him so. Try to identify those areas of your body which are especially sensitive and responsive. The next one, communicate with him. Don't talk too much. Or But remember that you cannot possibly know what you want. Start with her. Have you completed writing that? Try to identify those areas of your body which are especially sensitive and responsive. Afterwards, this is the one side. When both of you are head enough, I want you, the woman, turn you on your back so that the man can caress her body. Start with her face and neck and go down to her toes. But this first time, don't caress sexual organ. Skip her nipples, vagina, and clitoris, and again, both of you are concentrate only on what it feels like to caress and to be caressed. Stop when this becomes tedious for either of you. Now, it is the man's turn to receive. I want you, the woman, to do the same to him. Do either of you have a questions about this procedure? This is the one non-genital touching. It is taught. Now, at each point of touch, here, kindly listen, at each point of touch, 4 different perspectives are there. Suppose a man is touching the woman's back, imagine. Then how he is feeling when he is feeling the touch of the back of the woman. And what he thinks is the feeling of the woman when he is touching her back. The third one, from the woman's point of view, how she is feeling about being touched and what he is feeling when he is touching her. That is, each one having a direct and an indirect. There are, for man, there is one direct, he feels. And the indirect is, he imagines what the woman is feeling. For the woman, what she feels, and she imagines what the man is feeling. That is, each touch is having 4 dimensions. The 4 dimensions are entirely different. After this, the roles are reversed. The purpose of it is self-exploration and exploration of the partner, identifying which areas are pleasant, unpleasant, sensitive, or neutral to touch. Some areas are good for anybody. That is, everybody has to identify where the man is strong, where the woman is strong, where the woman is strong, where the woman is, or that is, you are strong in some areas, you are not strong in some areas. The woman may be strong in some areas. I like to be touched in particular area, and I will like touch to some other one in some other area. That is, everybody has to know whole of yourself and whole of your partner. That is the purpose of this stage. The second one is, these are the pictures directly downloaded from the illustrated book of sex therapy by Helen Kaplan. This is how she is caressing. Now then we go for the genital touching. Once the couple are comfortable with the non-genital exercises, they progress to touching the genitals and breasts using hands, lips, or tongue. Again, the focus is on sensations and not on the outcome of the sensations. Watching for erection, watching for lubrication or arousal is discouraged. The aim is to simply to experience the feelings of pleasure or touch. Now, the third one is integration. Normally, now at one stage, man is touching, woman is receiving. Woman is touching, receiving. That is only one section we are doing it. But in sex, both of the partners will be doing simultaneously. So, the sensate focus has to be integrated. That is, integrating the genital and non-genital pleasuring of the both partners. That is, there are 4. One is the genital exploration, non-genital exploration, and simultaneously both of them are doing. So the fundamental rule is in doing its integration. No part of the man's body should be free. No part of the woman's body should be free from doing anything. Suppose your mind is free, then you will wander. If your hand is free, you give a job to the hand, your concentration is only on the hand. So likewise, all the organs should be acting simultaneously in sex. In sex, every organ should be both of the partners, every organ should be acting simultaneously. And there is another thing called genital stimulation pressuring. That is, the man does masturbation to the woman does masturbation like movements, not till ejaculation. Ejaculation is not permitted. And the man, suppose the woman is doing masturbation like movements on the man, he receives the pleasure. And some women are more likely to give pleasure also, and it can be done with a hand or a mouth, or just like a blowjob. That is sexual stimulation. They should know what is sexual stimulation and how it feels for me, how it feels for her. In fact, in clinical practice, we instruct the couple, instruct particularly women. Most of the cases come for male problem only. We instruct women. You have to know which is his strong point. Suppose if you touch somebody at this point, he may be so excited, or if you touch the glans penis, he may be so excited. So you have to keep an idea where is his strong point. That you have to utilize when he is not active. That is when he is suppose somebody has a good erection by touching the glans penis, and in the next session when he is having a problem of erections, then you have to use that knowledge. It has to be kept for secret for the woman only. She should not let it out to the man. Otherwise, it spoils the purpose. So, in summary, Sensate focus is a stepwise training in bodily. This is sexual stimulation. He is doing cunnilingus. And this is integration of the genital and non-genital touches. This is utmost one, integration of the non-genital and genital touching. The man is doing, the woman is enjoying. You can see the nice enjoyment face of a badly drawn diagram. You can see the face so nicely, the feel of it, how she is feeling. So this is sexual excitation touching. Now, in practice of sex therapy, I go a little deeper. Now it is already 40 minutes over. So in the practice of sex therapy, the tips and tricks. So how I practice, that is, on the first day, I teach what is genitals. Ask them to identify their private parts. The man can see his own private parts. The woman can see his private parts. The man can see the woman's private part outside only. The woman cannot see her private parts. So ask them to take a mirror, ask them to identify the private parts openly with the aid of a mirror. Afterwards, by closing the eyes, you have to identify your private part, not naming. This is my labia major, this is labia minus, this is my vaginal opening. Like that, they identify their private parts. The first one. The next one is, the next session, teach the concept of sex therapy. So you have to instruct those people. You have to do whatever I tell you, whatever I instruct you. That's all. Don't go anything extra. Here we have to just like a teacher taking a cane. So we teach the concept of sex therapy. And in fact, in the majority of the instances of sex failures, the man is able to appear for he is having a good marks in engineering, IIT, good marks. But when he wanted to go for a interview, he fumbles. The man is having his own erectile capacity, but when he wanted to do sex, his mind is vacant. Just like you fail to face the examiner, even if you know the subject. The similarity is there. So here we have to impress upon the people, we are making a movie. Usually in a case of erectile dysfunction or unconventional marriage, I tell those people, the woman, you are the hero and you have chased the heroine. I am here to help you. You have to chase the heroine. Heroine is the man. So that finally, ultimately, he can trap or he can come or he can make her love him. And I am the director. The woman, in a case of male sexual dysfunction, the man is the heroine. The woman is the hero. And then she entices the man, that is, the hero entices the girl, ultimately succeeds in making her fall in love. This is the same technique. So here, non-verbal communication is far better than verbal communication. Then the next one is no talking. Non-verbal communication is encouraged. And There are 5 senses for us. In sex only we use the friction senses of the skin. But there are so many other senses like eye, ears, like that. In a sex, suppose the touch is failing. In a case of erection failure, the touch is failing. So then what you have to do? We have to ask those people to use the eye. Suppose if somebody is having only 75% of the sex is only touching. Suppose he is failing to do that one. If the sight is making him more, then he can do sex therapy or sex nicely. That is, if you fail in mathematics, don't worry. You may if you get good marks in science, you will be passing whole of it. Just like theory and clinical practice. Then undressing, the next step, I divide 20, 20, 20 minutes. So in an hour, 20 minutes for people entering and they're undressing together and they're taking bath together. It takes 20 minutes. And here there is a boss, there is a servant. Boss is not boss. He is there to enjoy, or she is there to enjoy. The other one who is doing it is a servant, you think, or provider and recipient. So they take turns. 20 minutes for the man, 20 minutes for the woman to become a boss and to become a servant. Then I told you when you are touching, there are 4 dimensions. Enjoy it. Don't look for erections. Here we tell people nobody can do sex. It will happen. So nobody can have an erection on demand. So don't forget about erections. You simply concentrate on what you are receiving. It happens on its own. If you want to check whether you are having erections, your glans penis head is far more nut than your main head. It won't listen to you. Your mind won't listen to you. If you are doubting your penis, it won't listen to you. Simply leave it. It happens on its own. Then talk to the girl. Identify his sensitive parts. Ask her to identify his sensitive parts. Keep it for yourself. Don't reveal. Then I instruct the girl, use this one as a weapon. His sensitive part is his weakness and it is your weapon. His sensitive part is his strength, but at the same time, his sensitive spot is his weakness, and it has to be used as your weapon in treating his sexual dysfunction. Then we review, and then together and separately, whenever they come together, we ask them, then separately, we ask them. Finally, once more, the second instruction. So once this non-genital is there, then out of 20 minutes, 10 minutes is condensed for the earlier class and 10 new class genital. Afterwards, like that, compression is done. Then genital stimulation and integration of genital stimulation. Now, when it is integrated, both are servicing and both are enjoying together simultaneously. Here the point is all organs of the man and the woman, all senses of the man and woman are occupied, leaving no space for thinking anything else other than sex. That is, we are concentrating, we are giving task to every organ of the person and the client. Now, this completes sensate focus. Now, shall I continue psychotherapy for female sexual dysfunctions, sir?
Yes, sir. Yes, sir.
Yes, sir. So, instead of going to everything, usually in a woman, the common things that come normally in a sex therapy, 90% of the cases is only unconsummated marriage or erection failures. Not 90, more than 75% of the cases. Because the good number of referrals I receive for delayed ejaculation or inejaculation in a man. That is one of the really troublesome things where it leads to infertility. And not more than 10% of the cases that come to me are from females. So in the female, it is not having lubrication, not having orgasm, or the common complaints with which people come. So now we go for the female sexual dysfunctions, how to manage. Normally, in sexuality, woman differs from men in many ways. In a woman, desire, in a man, desire, arousal is erection, and orgasm, followed by refractory period, follow a sequential pattern, a linear model. But in a woman, the desire, arousal, and orgasm need not follow the same pattern. At sex, a man is always an active partner. He should have erection and do coitus, otherwise sex won't happen. But in a sex, a woman is a neutral. In sex, a woman is in a neutral state, or tranquil state, or inactive state. She has to be aroused by the man. Mostly, she is a passive recipient partner of the sex. Mostly, don't talk of ideals, but mostly it is happening. A man has a spontaneous desire, de novo. His arousal and orgasm follow. A woman can have a spontaneous desire, but it is not uncommon. It is not common. Usually, the man initiates sex, the woman responds and develops sexual desire. This is responsive sex desire, not a spontaneous sex desire. Spontaneous sex desire and responsive sex desire are basing on the actions of the man. Suppose she had earlier previous good sexual experiences, she responds positively. If her earlier sexual episodes are not satisfactory, she may not develop desire also. But even if he is not having a desire, she don't object to his sexual advances. She keeps quiet or cooperates with him and let him get his job done. Sex happens. So sex happens in spite of the active participation of sex of a woman. And in woman also there are two varieties of arousal. One is a man gets an erection and a woman gets swelling and lubrication of her genitals. This is a point of erection. Solely on physical stimulation only. But this is subject to arousal, we can see it. But the woman has to feel horny. She should be subjectively aroused. This is called subject to arousal. When there is an object to arousal also, there will not be orgasm. When she is subjectively aroused, then only she will be able to have orgasm. In a man, the end point is ejaculation and orgasm. But a woman, the man may not last enough for her to reach orgasm. In a woman, orgasm is not mandatory. It is a bonus. Now, the sex mind of a woman, all cultures of the world assign roles for the man and woman. Sex is a male domain, not only in India, everywhere. Doing sex is his responsibility and enjoying the pleasure is his right. Responsibility at the same time right also. He uses woman as a vehicle to get his pleasure. Females are there to provide him sex. She having sexual pleasure is secondary. It is a bonus. This is more common in conservative societies. Here, everywhere, all over the world, even in Western countries, the man's pleasure is central and the female pleasure is secondary. Then, with this briefing, we go for the general principles for all the female sexual dysfunctions. Then, in all female sexual dysfunctions, you have to classify whether it is a primary or acquired. Self-explanatory. Generalized are situations, or in some situations happening, some situation is not. With some person it is there, with another person it is not there. Generalized, situational, organic or psychogenic. Then 50% of the female sexual dysfunctions, the cause is male sexual dysfunction. If a woman is not having a sex desire, she may not be having a sex desire, or the man is sexual function is not good, then she can't have desire. In the same way, for most of the female sexual dysfunctions are the result of male sexual dysfunction. Somebody is having a female ejaculation and it is continuing for many months together, then how we expect the woman to have a sex desire? She simply participates for her husband's sake. Then treat the comorbidities of the treat comorbidities which are contributing for the sexual dysfunction. Treat the modifiable biological factors like hormone interventions. Address the modifiable psychological factors. Some are anxiety people, some are worrisome people. Manage the relationship factors of the couple. This is not our purview today. Now we go for the individual sexual dysfunctions, female sexual interest and arousal disorder. Earlier, all female sexual dysfunctions are branded as frigidity. Later, a woman not having a sexual interest is called sexual interest desire disorder or sexual desire disorder, hypoactive sexual desire disorder. A woman not having lubrication is called female arousal disorder. Now, to separate, the woman cannot separate her desire and arousal, and the practitioner also in good number of instances mistake one for the other. Both of them are complementary, but both of them are intertwined. So now the word is changed as the word is changed as female sexual interest, female sexual arousal disorder. So for treatment of this woman, rarely a woman presents herself with for the lack of sex desire in her. Usually the man brings her, his wife, for the lack of sexual desire, or she is not active in bed. That is a common one. Female won't come on her own. The husband brings her for her lack of sex desire and she is not active in bed. So the purpose of the visit is to have good sex for himself, not for the benefit of the woman. That is, when she is not interested in sex and when she is not interested in getting a treatment for sex desire, then how we can solve the problem? Then why we should solve the problem? When she herself is not interested and is not having a desire, when she is not interested to get her desire rekindled, then why we should treat? As a physician, we should ask the question, why the clinician has to treat her? For example, a couple had 2 children in 10 years of their marital life, and even in poor sex life, the husband brings his wife for low libido. In her life, an equilibrium is set of marital and sex life already in 10 years of married life. She don't want to disturb that equilibrium. Whatever is happening, let it continue. Why I should try myself to get desire? So when she is not interested to get a low libido corrected, the results may not be satisfactory. This is so common in Indian scenario. Rarely a woman comes for lack of sex desire. Then in treating sex therapy, less sex desire for a woman is having an innate sex desire and has capability to get aroused, but it is masked by cultural norms and typical female sexual mind, just as we discussed. A beautiful face is hidden under a gungut. At Swagraph, the husband removes the gungut and does sex with his limited sexual armamentarium. One-sided desire and gets sex done. She don't have the occasion to unleash her potential. In sex therapy, her potential is unleashed. This is the basis for correcting the sexual desire disorder. The techniques are sensate focus non-genital, just as we discussed earlier, sensate focus genital, and the next one is at sensate focus. In these sensate focus, she learns and experiences the pleasurable points and sensations in her. Though through an instruction of the therapist, the participation of the man in her sexual task, the care shown by the man, equal importance given to the man and woman. Taking bath together, she realizes she comes into the sexual mood. That is, it may not be our techniques, but it is the concern of the man to get her treated. It is the participation of both the partners. It is enjoyment of the both partners. It is taking bath together. These are the ones that is going to make the mood, romantic mood of the couple. Then desire automatically follows. Then they go for a non-demand coitus. All through the process, the woman is in command of sex. Now, in non-demand coitus, the woman is in command of the sex. With good erection, lubrication, she mounts him, inserts his penis into her vagina. She stands still. She feels the warmth and hardness of the penis inside. I repeat, she mounts him from above with good erection, mounts him from above. She is in command. So she develops desire. Now she is the responsibility of to please her is hers only. She feels him, inserts his penis into her vagina. She stands still. She feels the warmth and hardness of the penis inside her. Then she contracts the pelvic floor muscles, just as we do Kegel's exercises. That is, then by these exercises, she feels the contraction of the strength of her pelvic floor muscles over the warm, hard penis. So she feels the pleasant grip of vagina over the penis. This is just like similar to a tight hugging. Earlier he is tight hugging. Now she is tight hugging. Her vagina is tight hugging the penis, hard penis. Then she experiments, she feels the pleasant grip. She experiments, she starts slow movement. Depending upon how she is moving, like this, fast, slow, this way, that way. She experiments. She is advised to be selfish. Ignore whether he is enjoying the process or not. She concentrates on her feelings only. Normally, the man uses the vagina for his sex. Here, in this way, here the woman uses the penis for her pleasure. Now she is dominating. Earlier, he used to use her vagina. Now she is using his penis. That is so much of mental satisfaction for the woman that I am the commander. That itself solves the problem. When they are tired and exercise is stopped, then she learns the feel of pleasure of the sex. She develops the interest and arousal sex. To give a simple example, you go to a restaurant, the food is good. You will develop the craving for food. And your mouth is watering at the sight of that food. You visit that restaurant often. Similarly, the desire and arousal. That is, the craving for food is the desire, and lubrication is the watering of the mouth. So, if the food is good, if food is good, then everything happens. Then later coitus done is in the usual way. This is the treatment schedule for female sexual interest arousal disorder. Now we go for the female orgasmic disorder. Female orgasmic disorder, orgasm in a woman is not mandatory for sexuality or fertility. 10% of women have never achieved orgasm in their lifetime. In couples having good marital life and sex life also, not more than 50% of the coital acts end with female orgasm. Even if the couple are good, even if the man is not having any problem, even if the woman is not having a problem, out of every 100 sexual acts, not more than 50% of the sexual acts will be having an orgasm. That won't mean that she is not satisfied. Even though she is not having a sexual orgasm, she is satisfied. So, orgasm and satisfaction in woman are two entirely different entities. In clinical practice, there are varieties. It can be lifelong or acquired. Here, a woman not able to achieve orgasm with masturbation and sex. The treatment is directed masturbation. Here, there are two varieties. Woman not able to achieve orgasm with masturbation and at sex also. The first step is directed masturbation. The woman is able to achieve orgasm at masturbation on her own or by our treatment schedule, but not in partner sex. The treatment schedule is this one. Sensate focus. That is that there are two varieties. One is the woman is able to have orgasm with masturbation, but not able to have orgasm with partner sex. That is one variety. The other variety is a woman not able to have orgasm even with masturbation or even with sex also. Two varieties are there. So, how to make a woman in these two things? The first step is you have to make a woman who is non-orgasmic at masturbation to be orgasmic at masturbation. The second step is adding or achieving orgasm at partner sex. That is the second step. Now, how to do it? Now, suppose a woman is not having orgasm at masturbation also, it is called directed masturbation. Directed masturbation, we have to direct her to masturbate. Is the technique of achieving orgasm at masturbation. One, identify her more sensitive part for sexual excitation. At sex therapy, they are able to identify what is the more sensitive part of her sex. She identifies her more sensitive part. That is at sex therapy, she identifies, not the husband. This is done with sensate focus. Then prolonged intensive stimulation of these areas. Prolonged intensive stimulation of these areas. In this one, she is permitted to use her fantasy, or she can use a sexually exciting material like a pornography, which she may like, or she can use a vibrator also. That is, her sensitive part is excited, more prolonged and instant stimulation is done. And she is encouraged to express her feelings at the time of her masturbation. Normally, woman will make some noises or lift her pelvis, or they move their body. They are encouraged to do it. And using her voluptuous language and pelvic thrusting also. This makes her achieve orgasm in masturbation. Most of the instances, we can make her orgasmic at masturbation, not with difficulty. There are some exceptions to cases where their obstinate masturbation is not permitted for a woman. We can't do anything for those people. Now, then second, when a woman is made orgasmic with the masturbation, then our job is to make her have make orgasm at partner sex. Here the steps are: a sensate focus. Once more, a sensate focus. They have to identify her own private parts which are more exciting, an intense foreplay. Next, man directly stimulating the woman with his fingers, mouth and tongue also. Direct stimulation of her exciting parts, genital parts. Then, when she is ready for sex, that is, she developed a desire, she is cooperating, at the peak of excitation, a peno-vaginal entry is done. Man over the top entry can be done, but the woman on the top entry gives better results. Then, in the woman on the top entry, coital thrusting is done in her desired way, preferred angle, using her highly excitable parts. This gives her orgasm. That is, in the woman over the top, normally in a sex, man's glans penis is the highest sensitive part. In the same way, clitoris and labia minora, clitoral hood are more sensitive parts for a woman. But at sex, the man's sensitive part is directly stimulated in the vagina. Woman's highly sensitive part, clitoris, is not directly stimulated in sex. So when the woman is on the top position, she can, if she bends her back a little, or if she does a rubbing movement, to and fro movement, not the thrusting movement like this, a rubbing movement of her body, sliding her body towards cranially and caudally, she is directly stimulating her clitoris over the penis. So, woman on the top, along with rubbing movement, half her grinding the penis over his penis, is the trick that works for her having orgasm. And woman on the top entry, she is the commander. Then she will be having an orgasm. So there is another technique called coital. This is the one. There is another technique called coital alignment technique, which are so easy. If somebody demonstrate it, so easy. Coital alignment technique is a nice technique for female orgasmic disorder. When the man enters this is the woman's vagina is in this angle. In this angle, woman's vagina is there. This is vaginal entry. The man is entering like this, and he is thrusting. The clitoris is here. So the penis is not touching the clitoris. What he does is after entry, then the man slides his body cranially towards about 2 inches, cranially, so that the penis is directly over the, now the earlier penis angle is 90 degrees to the vaginal outlet, to the outlet. It is, this outlet is around 65 degrees. Here the man is entering like this at 90 degrees angle. But when he slides forwards his body cranially, the penis is directly stimulating the clitoris, and the more sensitive parts, the labia minora are touched, and the outer one-third of the vagina is only sensitive in sex act. His penis, glans penis is directly touching. His glans penis is about an inch in thickness or a little more, whereas orgasmic platform is also an inch or a little more. So the most sensitive part of the male glans is sliding in, is inside one to the depth of only one-third of the vagina. This is called coital enlargement technique. You can see here the man's penis normally is directed like this. This is the woman's head. It is directed cranially and posteriorly. Here it is directed caudally and posteriorly. Now understood the position, the coital enlargement technique. Normally it will be like this. Penis is like this. But here it is like this. The clitoris is being stimulated directly. This is a nice technique. Very few people follow it. But it's such an easier thing once you learn how to tell those techniques, or a male doctor can demonstrate for himself how to do it. If the woman is not able to achieve orgasm in this way also, there is another thing called a bridge maneuver. The bridge maneuver is, at sex, in addition to the pelvic thrust, the man or the woman does stimulation of the clitoris simultaneously till she reaches orgasm. Now you can see the man entered the woman is lying above, and he or she is stimulating her clitoris simultaneously along with coital thrusting. So that means you are doing coital thrusting, at the same time you are doing masturbation. In due course of time, now the masturbation, now you are doing masturbation of the clitoris for about 5 minutes, later 4 minutes, 3 minutes, 2 minutes, 1 minute. She will be able to achieve orgasm by means of coital thrusting only. This is the treatment for female orgasmic disorder. This is the result. Now, vaginismus, good number of all of you are very well trained in treating vaginismus, but the reality is most of us treat, as a gynecologist also I too treated, most of us treat the simple cases which may not be real vaginismus only. Here, a fear of intimacy, a fear of sex, a fear of penetration, or real pain at sex, or fear of pain at sex. In these categories, the first one are fear of intimacy, fear of sex, fear of first night. All of these things are so simple to treat by means of counseling. It is not counseling, it is simple reassurance. Here, everybody knows involuntary spasm or constriction of the musculature surrounding the introitus and outer one-third of vagina interfering with penetration. Pain is not in vagina, it is in the mind. Psychosomatic fear of sex and penetration. It is phobic avoidance. Normally, everybody thinks that there is leviathan hypertonicity and hyperalgesia, more sensitivity of the introitus. Both of these things are, these last two things are not demonstrated. It is only phobic avoidance and fear of penetration. So this is, everybody knows Liebman's classification. Then the treatment for vaginismus is sex education and reassurance. A simple measures like anxiolytic, a lubricant cream, or an anesthetic cream. Then pelvic floor relax. Normally, we do the first two things. And in fact, in the Lamont 1 and grade 2, These two is enough. The first two interventions, sex education, reassurance, and simple measures are enough. But from then onwards, from the third onwards, they need definitely some interventions. That is spasm of the grade 3 and grade 4. That is pelvic floor muscle relaxation exercises. When we tell that pelvic floor muscle relaxation exercises, everybody's mind goes into the Kegels exercise only. And in fact, Kegels exercise is constriction of the pelvic floor. But here our job is relaxation of the pelvic floor. Everybody knows how to teach Kegels exercises to constrict or contract the pelvic floor muscles. But here our job is to relax. It is not a difficult one, but we are not comfortable in teaching. That's all. Here, in managing vaginismus, the techniques are very simple. That is how to do this muscle relaxation exercises. Everybody has to be very much 100% sure of comfortability with pelvic floor relaxation exercises teaching to the couple. In the supine position, this is just like a child position. Child will be sleeping like this. At the same time, she has to contract her abdominal muscles, and then she has to do violent or forcible farting, letting out her gas by contracting her tummy. This is in this position. Or the second one, in a squatting position, instruct her to squat as if she is using an Indian toilet. Take a deep breath, contract the abdominal muscles, and push downwards as though she is passing a difficult stool. She sits in an Indian toilet and instruct her to push down her bowel so that the external sphincter opens. Simultaneously, vaginal outlet also, that is the pelvic floor posterior anal is open. Much more easier for our obstetricians. Obstetricians may understand better as if ask her to bear down at delivery. While bearing down at delivery, we are pushing the tummy inside and then asking her to relax her pelvic floor. Bear down exercise is far more easier. This is most of the cases are referred to me because they instructed the woman Kegels exercises without knowing that this is the reverse Kegels exercise that has to be done. That is the reason why I am taking a little more trouble to teach. So in grade 3 and grade 4 exercises, grade 4 vaginismus, this technique, the first step is pelvic floor muscle relaxation exercise. The Sensate focus of Masters and Johnson, just to make her relax herself, just to go into the mood of fantasy mood or mood of sexual excitation. It is not helpful, but it's sexual excitation. And graded vaginal dilatation is not a sex therapy. It is a systematic desensitization. In fact, when we are dilating vagina has to be dilated when there is a stricture only. Here there is no functional structural stricture anywhere. Or where the introitus is normal. It is only functional spasm. So to relieve that one, where is the role of dilatation? But the dilatation is meant to systematic desensitization of the contracture that is done. Everybody knows how to use the vaginal dilators, but much more easier way. Gradual vaginal dilatation is a procedure. It is not a true vaginal dilatation of the vagina. There is no organic stricture. Then where is the question of dilatation? It is a functional spasm. It is not a true dilatation of the introitus. It is rather a dilatation of the mind. Surgical procedures like hymenotomy or making her episiotomy like incision or a mechanical dilatation under anesthesia. These are practiced by good number of people. They are ineffective because they don't address the psychological factor. The steps of graded vaginal dilatation are: number 1, self-dilatation by the woman. This is the standard technique to be adopted. Everybody gives a vaginal dilator and asks her to push it down inside her. It is not of any use. First, she has to relax herself by means of sensate focus, then self-dilatation of the woman. Let her visualize the genitalia with a mirror. Touch the mons pubis, labia, vulva and hymenal opening. Let her touch it, that's all. Insert a lubricated little finger gently through the introitus. Hold it for a short period of time. withdraw, and repeat like this for a few times. And progressively insert ring finger, middle finger, thumb, and two fingers gradually one by one. It has to be done in a leisurely way, not in a fast pace, leisurely way. Let her do it. Then alternatively, graded vaginal dilators also can be used. Sensate focus can be done at the same time. After she is comfortable with inserting her two fingers inside, then she may be fearing the penile entry. They feel that penis is bigger one. Earlier, my vagina is smaller is the concern for them. Now the concern is penis is bigger. So, with adequate foreplay, the husband gently introduces a finger. The woman holds and guides his finger to maintain control. The woman holds his finger. Then she inserts his thumb into her vagina. Then, once the finger entry is tolerated by the woman, penile entry is attempted with ample lubrication. Entry may be performed by the woman on the top position, allowing her control over penetration, or with the man on the top. After penetration, the couple remains still until the woman is relaxed. Only later thrusting is initiated. Here, the key teaching point is the ultimate goal in vaginismus therapy is not merely penetration, but the resolution of the fear and avoidance of sex. Graded exposure, not exposure immediate exposure. Slowly you have to do. Relaxation and couple cooperation gradually transform the sexual experience from one of anxiety to one of confidence and pleasure. So these are the steps of doing vaginismus treatment. Now the time is over. If you want me to continue with erectile dysfunction, then unconsummated marriage or premature ejaculation or delayed ejaculation, I will continue. Otherwise, this completes female. The male is unconsummated marriage, erectile dysfunction. More important for a gynecologist is treatment of a delayed ejaculation or an ejaculation in a man at partner sex. This is separate topic, and if you want me to continue, I continue. Otherwise, we stop this one and we will interact. It is up to you, sir.
Yeah, let's have a question answer session.
Yes, sir.
Sama, is there any question? Nahi, Sagi?
Yes, sir.
Namrata? Is there any question?
So, few questions. How long does it take to see results during this session?
The results will be seen. The results will be seen immediately in 2 months' time. Normally, here, last slide I will show you. The result will be seen immediately. The success of sex therapy, it is only personalized. Somebody who is experienced in doing things, it takes so long time for us to learn and then to practice, to teach also. Even for me, when I have received good number of referral cases from gynecologists or from sexologists or urologists to do sex therapy. Then also, if 10 people are referred to me for sex therapy exclusively by urologist, not more than 2 people will be accepting for sex therapy. Even in those people also, this is the result. That is, they are mentally made up their mind to get treated. They are ready to get it treated. Even in those patients, in erectile dysfunction, 80% success can be given. In a delayed ejaculation, it is not. If it is 1/3 of the people, 2/3 of the people only. Other people we can't do it. In vaginismus, almost all of the techniques of bottle injection are not necessary. They are fancied one only. And for premature ejaculation, I doubt whether it is still helping or not. And the result will be seen in 2 months' time. We have to give a target period. Otherwise, these people will be prolonging the sex therapy eternally, boring you and because just like somebody, if you yesterday I have been in Tirupati, so I have Tirumala, they go on foot. If they start to go on foot, it takes 4 hours for them to climb whole of the hill. Suppose they after about a halfway through, they felt relaxed and then they have sat there for a while, then they cannot go up. If they are going above continuously, then at that pace only they can do. Suppose if you instruct them, so you have to be a good instructor, at the teacher at the same time instructor. Otherwise, don't leave them alone. They have to follow you. Then whole of the procedure can be completed in 2 months' time. In fact, earlier when there are intensively people are coming, for a good number of US clients will be there for us. They come stay here for about in a month and then they get it done. We used to complete in 1 month time also, but usually it takes 2 months time. And the result will be seen immediately after 2 months time. There is no waiting period for it. The result is this much only. It is not 100% sure.
Sir, you mentioned about there are you give 4 sessions of the Sensate focus and then 4 sessions about the specific management. So in that 4 session, how will you go non-genital? How many sessions for genital session, or it is combined everywhere?
Yes, sir. Non-genital is one session.
Okay.
That they practice at home 4 or 5 days. In a week's time, 4 or 5 days, they practice at home 1 hour each day. First, I teach them non-genital sensations focusing. Then they go and then practice at home 1 hour a day for 4 or 5 times. At least a minimum of 3 to 4 times is needed. But usually people take about a week after a week because practicality should be there. So normally the couple has to come. Both of them are intelligent people, working people. So you do only Saturday and Sunday for those people. Usually it is like that. So they can come once in a week. Otherwise their job is lost. So the next one is genital sensations. So when they come for the next one, genital sensation exercises, earlier I told you 20 minutes is given for the woman to do and the man to enjoy. 20 minutes for the man to do and the woman to enjoy. In that 20 minutes time in the genital session, 10 minutes is devoted to the non-genital sensation session and 10 minutes exclusively for genital because the body is bigger one. So we condense that one into 10 minutes because they already learnt it. Then 10 minutes is for genital sensations. Afterwards, the next one is integration of the non-genital and genital sensations. We teach them and then they practice 4 or 5 times at home. Afterwards, sexual excitation sessions, 3 or 4 sessions only. So total put together, not more than 4 sessions. That is 4 sessions into 4 times. Total, this is for sensate focus. For the other ones, so for a vaginismus, it won't take much time. Usually they not more than about a month they take. For an ED, usually they take 4 sessions. For a female orgasm disorder also, they take 4 sessions. That is, they come and if you are not satisfied, here one point is, suppose they are able to practice nicely, they are cooperative people. In one session, they are not able to progress further. There is a hitch. And everybody bothers about, ask them to repeat with a little more interest. Even then, if they are not doing, that is a boon for us. If they are not able to do it, there's a boon. That means we have to identify these people are having a block, that man is having a block at that particular point of one. Then our common sense and our knowledge or our experience will tell us, oh, this man is having a problem at this step. He may be having a problem at looking at the vulva. He may be having a problem when he is being touched at a particular place. Then there is a deep-rooted problem at that point of time. Suppose a man is severely punished when he is doing masturbation by the parents. He may not be having erection or his mother has beaten him at that time. He may be having a problem of erection in sex life. That means the problem is not today's, it is a remote one. So that one, their additional psychotherapy techniques has to be done. That is the additional. There we usually do, not because of we are trained psychotherapists, but usually experience teaches us how to manage these things also. But theoretically, it has to be sent to a psychotherapist also. But usually we don't send it. Yes, sir.
And sir, one more thing regarding this non-genital or genital central focus therapy. What type of material do you use? Do you use any picture or a video or something, or how do you go about it?
No, sir, no such thing is demonstrated. Number one, on the first day, to teach them science, we show them the external genitalia and internal genitalia of the man and woman. Afterwards, no such demonstration is done. In fact, very simple. I teach. Suppose I am teaching it. Ask them to touch every inch of your part, your face, like this. Every inch. Every inch has to be recorded in the mind of the person in 4 dimensions. I told you, and especially take a little more interest. There are some sensitive areas for a man and a woman. Normally, it is this one, this one, this one, earlobe, nape of the neck. Just like as people show in a movie, they will be biting the ears, they will be biting this way. And around the nipples, around the umbilicus, inner aspect of thigh, around the anus. All of these things are more sensitive areas. We like them to concentrate on those areas more than other areas. So it won't take much longer time. Once we know.
And sir, what about the penetrative sex during sunset focus? Only after all the sessions are over, then you allow the penetrative sex, or in between they can go
So
about
during
it?
sensate focus, penetrative sex is not permitted. Even orgasm or is not permitted. During sensate focus, it is not permitted. You should not ejaculate also. But because man cannot tolerate after looking at those things for good number of times, usually woman can control, but man cannot control. So we give a relaxation and then ask him, you do your masturbation separate. Once the sex therapy starts also, ejaculation not permitted, because in ejaculation failure, there are two things. One is he maintaining erection, number one. Getting erection, maintain erection. The second one is he maintaining erection till ejaculation. When his concentration is on erection, he fails. Once he entered also, when he is concentrating on ejaculation, he fails. So ejaculation is the last step. So that comes in the unconsummated marriage and ED sessions. Suppose they just like in a case of female orgasm disorder, also I told you, in a stepwise pattern they have to go.
Sir, you in this slide only, you have not mentioned about the interest and arousal disorder, or is there any success rate for the sunset focus, or it is not that much effective in when there is a problem desire and arousal
Yes,
in
for
female?
desire and arousal, it is sensate focus is a must.
Okay.
For desire and arousal, sensate focus is a must one. And in fact, after doing sensate focus for first 3-4 sessions, the woman will be complimenting you. Sir, till now, I don't know that I have a body of so responsive. And if I say you wanted to continue with the other, even if my husband is not able to penetrate me, I am least bothered about, sir. My sensations to me when he is fondling me, my sensations, the pleasure I receive when he is hugging me or when he is doing the foreplay, that is enough for me. That is enough. They say, even if they are not able to have erections also, they are nicely able to cooperate. So for the sex desire, interest, arousal disorder, sensate focus is the one. Afterwards only comes penetration. Once they are comfortable with this one, penetration is to show people that they are having a good feel. There I told you that the woman will be entering, she will be feeling the warmth of the penis, warmth of the hardness of the penis, squeezing of her feeling of levator muscles around that one. That means she is in command of the situation. I am the boss. Instead of man using the woman's vagina, here woman is using the man's penis for her benefit. So be selfish. Don't bother about your husband, whether he is bored or not. Don't bother about. That gives her a free hand. Good number of women, their inner aspect is to command, but they are not given a provision to command. So this gives them release. That is, she is taking off the shirt of the man, not the man is taking off the gungut of the woman.
Sir, what are the common challenges couple faces during the stage one of therapy, and how do you guide them through it?
To sensate focus, usually no. People will tell, good number of the people, the present generation, good number of the people, they want a result oriented approach. Result oriented. Today I touched my wife, I don't have anything. That is, that depends upon the type of the personality of the people. But usually, when we are selecting, that sort of thing will never happen because only that sort of people who wanted to be patient, that is, the patient should be comfortable about herself or himself. They should be having confidence in the technique. Usually in sensate focus, we don't have anything. Usually in sensate focus, some people, suppose in sensate focus also, in the genital sensations, I ask them to do the touching, the man touching the wife's genitals, not exciting the genitals. Touching the genitals is different, exciting the genitals. Then I instruct then when the man is touching the clitoris of the woman, how he is feeling good or bad, how he is imagining that the woman is responding, the woman herself is how she is feeling, she knows it. How nicely the man is responding. That is, 4 varieties will be there. So, this way they learn themselves. So, no problem we will encounter. Rarely, the next step is once when they are accustomed to have a touch of it, then I ask them to do with the help of the lips. Much more nicer thing is with the help of a rolled tongue. Rolled tongue is just like a small pencil probe because the whole body is having this much amount of area, but the private parts of a woman or man having only this much area, not more than this much. So in that one, earlier we teach those couple, you touch every inch of the man's body or female's body. Here we teach them every half centimeter of the woman's body because the clitoris is only half centimeter. Then when the question of how you can do with a finger, but instead with a rolled tongue. Rolled tongue is such a pencil like you can roll. Then once with a rolled tongue you touch it. Here I specifically instruct those people to do with the lips and rolled tongue. Here normally we do sex with a touch. The next one is the next important is sight of the private parts. Use more excitation. Here when we are touching that one, a rolled tongue, the private parts of woman, they are able to taste it. They are able to smell it. That is out of the 5 senses, 4 senses already used. If one sense is failing, the other sense compensates. I told you, if you fail in mathematics, get good marks in additional marks from these things. So altogether, all the 5 senses has to be used by everybody. That is the essence of it.
One more question, sir.
So,
How
sir,
do you
in
counsel?
non-genital or yes, yes.
Sir, how do you counsel couple when one partner is reluctant to participate?
When when one couple is reluctant to participate, usually this comes. Very simple logic. Usually majority of the things are done for unconsummated marriage. Usually. That is a point where you have to do it. That's all. There is no question. Otherwise, the annulation of marriage will be there. Divorce is going to happen. So we threaten those people. That is, we use a stick also there, not a carrot. Now you are using a carrot. Now we use a stick. Suppose the man is not interested to get things done. Then to get things, this is the trick I am telling you. That is, if the man is not interested in it, if you don't cooperate, the only thing option for you is divorce, shame in the public. He is definitely forced to come. The second scenario is more common. Suppose the woman says, why, when he is having a problem, why I should cooperate? If you don't cooperate, you want to, there is only option is you have to get a divorce. Definitely. But if you give divorce without cooperation, this is a trick I play. If you give divorce if you demand divorce without cooperation, then the fault lies on you, not cooperating. If you cooperate and the system fails, you can fail the system. If the system fails, then you are having a right to ask for a divorce. Understood the difference? Earlier it is an option for her. Now it is right. Suppose she cooperated her nicely, then still he is not able to have erection. then she is having a right to ask for divorce. Everybody will support it. So this is a carrot and then stick policy I use. What is the profit for you if you cooperate? What is the loss for you if you don't cooperate? Then everybody comes to the line. Nobody will be objecting. Everybody follows. Rarely 9 out of 9 cases will be 9 out of 10 cases will be continuing throughout the sessions. Only one will be dropping. Not because of the problem of the couple, because of the intervention of the parents of the couple. Intervention of the parents of the couple is far more problematic than the problem of the couple. That is the interaction of the couple. Then the father of that girl or the mother of the other, why I should send my daughter to an inefficient man? Why my daughter has to cooperate? Then we have to threaten those people. If at all your son-in-law is not able to have good erection, in spite of your daughter cooperating, then you can demand good lot of punishment money for your daughter. This is a simple trick, sir. Suppose if you don't cooperate, then they don't give you divorce. What you are going to do? The man is having a right not to give a divorce. It goes to the court. So we can bring those people across the table. Almost all of the people. This needs a little social interaction and then a little common sense and using our authority of us over the couple and over the parents of the couple. We should be authoritative at that time because they don't listen to anybody. They listen to you because they came for a end stage for divorce. But other things of not having a desire, who is bothered about? Oh, if a woman is not having orgasm, it is her for pleasure only. That's all. But ED and no ejaculation for a man and vaginismus, these three things should be treated. Other things is for pleasure, not for, this is for failure. So usually everybody comes on the boat.
So how do you adapt Sensate focus therapy for patients with chronic illness?
That is chronic illness. The chronic illness has to be treated. That is different matter. Hypertension, usually the Sensate focus therapy usually is meant for younger people only. Usually, isn't it? All of the vaginismus cases, ED cases, all of them are usually below 30 years of age. We don't expect those people. Suppose somebody is having a psychiatric disease, that is a different matter. The psychiatrist teaches them. Once he is psychologically comfortable in getting a treatment, then only they come to us. So all other medical diseases, in which way we are concerned with? So you are talking of female arousal disorder, female orgasmic disorder in a case of menopausal woman, or in a case of woman having less amount of testosterone, isn't it? So those cases won't be coming to us. A postmenopausal woman will never come to us for having sex therapy for a no lubrication. It is a medical disease. The treatment is treat the manageable or modifiable biological disease. I have given a slide. Modifiable biological disease as treated. Modifiable psychological disease we have to treat. Then only comes the question of sex therapy. So in younger people, this modifiable medical
as per
disorder.
you, yeah. So in postmenopausal woman, there is no role of Sensate focus therapy. Only this hormonal therapy is only.
Usually there is no, because they already experienced arousal. Why to teach them new? There is a clear-cut biological reason. So Sensate focus is for psychogenic sexual dysfunctions only. It is a biological sexual dysfunction post-menopausal. So there is no role in it. Once there are people, very rare people will be there, such things. A couple may come to us in a second marriage at that elderly age group. A woman who is very active in bed till she underwent a surgery and then she lost the husband and then she marries another one. There rarely the newly married couple at 40 years of age, they may be coming. But usually almost all sex therapies are in younger age group people only. Why a woman after menopause? They are not worried about a lubrication part. Even if you tell those people, and in fact, in Indian scenario, I usually tell people, The mind of an elderly man after 40 years of age is a nut-like thing. Nothing new suggestion enters into that man. The younger people's mind is still malleable. So malleable people only we can do. A 40 years man, is he going to change his way, the way he has to do, touching younger people will be able to do. But elderly people, particularly in Indian mind, it is always fixed one. It is a coconut shell like thing. Nothing new suggestion won't enter him. The younger people's new, that is, you have to bend the people's mind when it is a twig, not when it is a tree.
Okay, sir.
Is there any other question?
No, already covered, sir. Vaginismus and erectile dysfunction queries are covered.
So erectile dysfunction, ejaculatory dysfunction of a man, that is a different topic. If you want, that one has to be related because it is so difficult. You are able to hear me for 1.5 hours. It is so difficult because it is an abstract subject. I tried to make it as light as possible, and this abstract subject teaching is so difficult for us. It's demonstrating how to we do. That is demonstrating in a workshop to a group of people how to do sex therapy is far easier. It takes 2 to 3 hours. We can demonstrate there. You take a dummy or a volunteer there. Then we demonstrate how to touch here, how to touch here, how to feel. What is the response of that? That is by making people role play. We can demonstrate. It is a separate sex therapy session workshop. Takes 2 to 3 hours. Some people, I taught the same thing for a Bangladesh Gynecological Society. Some time ago, I have been there. That is a different matter, sir. That is a long time procedure. Nobody can listen this much length of time. And making a abstract thing into word form is so difficult for me. So I have jotted down everything because our English and then our vocabulary is not that much good to express what we think. What we think is correct, but expressing out in precise words, in sensitive words, wanting and getting wanted, interested and interesting partner. Everything is different words and everything carries different meaning. So it is so difficult for anybody to teach sex therapy, sir.
Thank you, sir.
Yes,
Sir, any final insights from Dr. Neeraj sir and Dr. Apuba sir? We can proceed for vote of thanks.
Thank you very much. It was really enlightening for us to know about the sensuous focus therapy because we were very much eager since long. We should be more aware about the sensuous focus, how to go about it, how whether we as a gynecologist can also do it or not. So many questions answered by you today. So we are really grateful to you.
And in fact, a male gynecologist can do better always. Male gynecologists know how to deal with a woman. Usually, a urologist or psychotherapist is not comfortable in dealing with a woman. We are very much comfortable in dealing with. So, a male gynecologist knows the mind of a male just like his husband also. Mind of a female just like is a patient. So, I am privileged in that way. That is the reason why I am able to do sex therapy. In fact, psychotherapists, the psychiatrist won't do sex therapy, sir. I talk to psychiatrists also over sex therapy, teaching sex therapy to a psychiatrist. That is a different matter, sir. So now, this is the slide you are able to see, sex therapy, a clinician's guide. This is now out of print. This is sold out. This is written by me under my direction of my teacher, Dr. Dega Narayan Reddy. It is on the stands, but it is out of stock now. It is sold out. But if at all you wanted to get this book, you know, Hemant Joshi, good number of people may be knowing, that is Hemros Pharma.
Hemros Pharma.
Is there. Hemant Joshi.
Yes.
And then he will be able to give, if you say, I wanted some books, then we get it reprinted. It is out of print now. This is released for 2 years ago. This book is released 2 years ago. then it is out of print now because all the copies get exhausted recently. Then we have to republish it. If at all you want, anybody can purchase. If at all is not available, ask that Hemant Joshi of Himaros Pharma. Everybody knows that man is the owner. He was earlier in Sanzyme, Pubergen injection. Earlier he was selling that one. All of you may be knowing him.
Yes.
Yes.
There are so many things to learn about. So we will definitely have some sort of workshop because we want to know more about the how to take proper history, different counseling method, and then sex therapy. Also, we want to keep some live workshop with you in future. Definitely, sir.
Yes, sir. I will be happy to support to enlighten people. I am a gynecologist. Tell me, I know the difficulties faced, and then gynecologists are very much reluctant to learn new things,
Yes.
to venture into new things because it is not lucrative for them. Because if I do one cesarean, it takes hardly less than 20 minutes for me, but this takes 6 hours to 8 hours for me, and the payment is not much. The remuneration is not much. We are directed always delivery, baby crying. Over. That means we see the result instantaneously. But here everything is not under control, our control. Everything is in the control of the clients or the patients. But ultimately, so people who are busy, they should not do it. They should not learn it also because it's not remunerative. If you do, even if you do for 6 to 8 sessions, how much they are going to pay you? So it's not a paying profession, but we do it because nobody else is doing it. It is our job. I am so leisurely now. I stopped practicing gynecology.
No, no, sir. It's not only about the financial aspect. Sir, it is not only about the financial aspect, but we that's why we have started this forum, SexMed Connect, because we want to teach gynec. Because unless we gynec promote the sexual health, there are so many issues in the female patient. They are very
Yes,
reluctant to
sir.
come out. And we as a gynecologist can help them very much. And so that's why that our this humble effort that every gynec should have some basic knowledge about the sexual health, and that's our passion and aim.
So if at all you want me to talk anything in or online, offline or online, I will be ready because I talk only for the national conferences and I talk for Pfizer people to spread their Viagra's. I talk to Jairus Cadila people to talk about Evanext, Evanofil tablets. I am speaker for those people. They ask me to talk. That's different. But every sexology conference, I talk on something which is not common. ED is so common problem. But I talked on how a pornography, how it is affecting people's lives recently, pornography, and how to identify and manage female homosexuals. It looks so silly, but it is so common, and we are going to face it in the next 10 years. How to manage female homosexuality. Yes, sir. This comes for us. How to manage
Thank you, sir.
the female
Naisargi, are you
sexual
there?
property.
Naisargi,
Yes, sir.
Yes, sir. Yes, sir.
vote of thanks. You can
Yes.
put on your video first and
Yes,
then.
sir. Good evening, everyone. And on behalf of all participants, I extended my heartfelt gratitude to the organizing committee for this excellent CMEs on Sexual Health Ki Parsala Episode 1. A sincere thank you to esteemed faculty and speaker for sharing their valuable knowledge, experience, and insight which have enriched our knowledge. I also wish to thank the sponsors and supporting team who worked tirelessly behind scenes to make this event seamless. Most importantly, I thank all my colleagues and delegates for their active participants, discussion, and enthusiasm, which made this conference truly interactive and meaningful. With great appreciation in my heart, I look forward to many more such opportunities for learning and collaboration. Thank you.
Thank you. Thank you, sir.
Thank,
Thank you,
It was
thank you,
Naisargi.
so
Neeraj Yadav
nice of
sir.
you.
Thank you,
Thank
Namaste,
Abraham
you.
sir.
sir.
Thank
Thank
you
you,
from
Satyanarayana
Medisage.
sir. Thank you, Naisargi. Thank you, Medisage.
Thank
Yes,
you.
sir.
Thank you.